Hey folks, this is Scott Weingart, and this is the EMCrit podcast. Today on the podcast, the Surviving Sepsis Campaign 2026 guidelines. The good, the bad, and the ugly. So we're going to talk about a lot of stuff with our guest today, Haley Prescott, who is the co-chair of the committee and the lead author of the guidelines. So some of the things we're going to go into in this episode, and I really enjoyed this episode, so I think you're going to love it as well, is the idea of our guideline writers, especially Surviving Sepsis Campaign guideline writers, just writing guidelines, or are they somewhat responsible for the pipeline from guideline to quality measure to performance metric to pay for performance metrics? And you might say, oh, they're just writing the guidelines. It's not their fault or problem. But prior chairs, not Haley, but prior chairs of the Surviving Sepsis Campaign have also then gone on to directly write the quality measures and advise on the performance metrics. So there definitely was a clearly established pipeline. And that being said, if there were none of these metrics in my country, the United States, I'd have a lot less of a problem with some of the pieces of these Surviving Sepsis Campaign guidelines. But I am in the United States, and therefore I have to look through that lens. So you'll hear a bunch about that. You'll hear about the difference between strength of recommendations and quality of evidence. This is a big one for these guidelines in particular, but all of the Surviving Sepsis Campaign guidelines. Now, normally I agree with clinicians getting together, as long as you have a broad-based consortium of clinicians, and making recommendations where evidence does not yet exist. I think that's fine. And in fact, if I was to write guidelines, and in the guidelines I have worked on, I have strongly fought to say this is good clinical practice, even though we don't have evidence yet. The problem I have with the Surviving Sepsis Campaign guidelines is in many cases, they are putting out recommendations where there actually is evidence, and it does not comport with those recommendations. That's more problematic. We'll get into some of those. The next thing is, and this is not something I disagree with, but some of my colleagues have, is guidelines like this really are written at the level of lowest common denominator. Now, Haley and the campaign may have some umbrage at that. They might say we're writing above lowest common denominator. I don't think they really are. You can't write guidelines really above lowest common denominator. That's just how the nature of guidelines. And so a adept advanced clinician should be performing at a level higher than the guidelines. Guidelines are always a problem when they drag that adept clinician down to the level of guidelines. And I'm not saying necessarily all of the guidelines here are doing that, but it's definitely a worry. And it's definitely a worry when writing any guideline. That's why they should be guidelines and not rules. Now, I think Haley and any of the Surviving Sepsis Campaign people would say, Scott, it's in the name. It's a guideline. It's not a rule. Sure. Now, the other side of that coin is I had solicited from my friends any recommendations they had for questions I should ask in the course of this podcast. And Corbin Haycock, who is just a brilliant emergency physician, physiologist, he said he didn't like the vasopressor recommendations. It's too prescriptive and it's too, cookie cutter. It's just start with norepi always and then add on vaso if this and epi if that. And he's like, that's not how you treat patients. And I agree with him. That's not how I treat patients. That's not how you should treat patients. I don't fault the guidelines for this. This is, again, it's a lowest common denominator. This is a good use of lowest common denominator. Give people who may not have a excellent strategy or paradigm for how to handle vasopressor escalation in patients with septic shock. Give them a recipe guide, right? Give them the cookbook medicine. And then if they're smarter than that, then they could move past it. Now, the problem always comes people who think they're smarter and they're really dumber than the lowest common denominator of guidelines. But I don't fault them for their vasopressor section. Now, prior chairs I have dealt with and have recorded episodes with have been a little condescending, a little openly prejudiced against emergency medicine and other specialties besides critical care. That is not Haley Prescott. In the 2 conversations I've had with her, I found her to be smart, open to ideas, not at all arrogant, and just delightful to talk to. She's also a good sport because she tolerated my somewhat difficult debate style with aplomb. And I think if I had a debate myself, I would not have handled it as well. So in all ways, I am so happy that she was co-chair of these guidelines and that she was willing to have a conversation with me today on these guidelines. So, one more thing. I can't give CME for this episode. Haley does have a conflict of interest with Orobac Therapeutics. They have no actual marketable product right now. There's nothing actually out, so it could not have influenced the guidelines. But I have a policy. I do not offer CME to any conflicts of interest, even if they're not directly relevant to the topic of discussion. I just don't do it. So we'll find some other episode in the coming weeks to give you CME for. So this will be a non-CME episode. With that, let's roll right into the interview on the Surviving Sepsis Campaign Guidelines for 2026. So we'll start with the same question I always start with, which is, who are you and what do you do?
Yep, I'm Hallie Prescott. I'm a pulmonary critical care physician at University of Michigan, and I have had the honor of being co-chair of the 2026 Surviving Sepsis Campaign Guidelines for Adults.
Absolutely. And they've just come to press, and there's a lot of good stuff in there. We will be concentrating on the more contentious issues, obviously, but I don't want to lose sight of there's great stuff in there. So we shouldn't think that just because we're hitting on these issues that the entire thing is poisoned by that focus.
Very good. There is a lot of content in there. I agree.
Yes. All right. And the lens specifically for this discussion will be the early treatment of the patient, just given the focus of EMCrit on acute resuscitation and critical care. So I'll leave the later critical care to my betters. So I guess the first question I'd have for you, Haley, is you folks create guidelines, but we know there's a pipeline in the United States to those guidelines being used for things like performance metrics, pay for performance, and things like that. And of course, that's not your direct responsibility as a committee, but we have to see the clear movement from guidelines to CMS measures. Now, you folks have addressed that somewhat by saying conditional recommendations are less likely to be suitable for rigid performance metrics or enforcement. But it's not the conditional recommendations that give me pause. It's the fact that many strong recommendations in the guidelines are based on low or, more concerningly, very low levels of certainty of evidence. Shouldn't that be what that statement is reflecting, of measures that are based on very low quality evidence are less suitable for performance measures?
Yeah, I think this is why we try to have guidelines be as transparent as possible. Every single statement there has a certainty of the evidence reported directly out of it, as well as the strength of the recommendation. But yeah, I think you're right. They're not 100% aligned, but obviously the certainty of the evidence is part of this formal evidence to decision framework that we use when we go from evidence into making those recommendations. There are like a handful of strong recommendations based on lower certainty evidence, but there's not a lot. And in fact, there's not a lot of strong recommendations in general.
Sure, though some of the ones that will be contentious as we discuss this are recommendations that are strong with very low certainty evidence. For instance, the patients with probable or definite sepsis without shock should receive antibiotics within an hour. One of the, in my mind, the most contentious ones is strong recommendation, very low certainty evidence. And based on the deliberate statement made in the guidelines, that one would be one that should be taken up as a pay for performance measure because it is a strong recommendation. Shouldn't that statement have been both statements that are conditional recommendations or those with low or very low certainty evidence should not be suitable for performance metrics?
I don't know. I'm reticent to say like nothing can ever be used for performance measurement because it's quite rare that we do issue strong recommendations on low certainty evidence. So I still feel that is the kind of more important thing in terms of helping to guide like what is appropriate.
All right. Maybe as we go through, we'll see how many of the contentious ones are strong with low or very low certainty evidence.
Yes.
All right. So the next thing I'd pose is, and this is more philosophical, so we'll see how it hits you. I think both of us agree that septic shock is a critical illness that needs timeliness and that patients absolutely, if not treated properly, have a clear path to greater mortality and morbidity. It seems the flavor of the guidelines are that sepsis is a critical illness. And I say that simply by looking at the intonation around things like timely antibiotics, considering giving large volume initial fluid resuscitation, all of that requires really alacrity that's only found when we deem a patient illness as critical. When aortic dissection gets the CT scanner cleared, we knock everything else out that we were doing and we get that patient to CT so they could get their vascular surgery intervention. And I put septic shock in that same category. Do you folks consider sepsis to be a critical illness?
I would say yes, it's a time-sensitive illness. If you look at people who meet sepsis criteria, their 30-day mortality is 17, 18%. That's like for the state of Michigan in our statewide registry using like systematic approach to screening for sepsis based on arriving with infection and clinically significant organ dysfunction. So that's a high mortality rate. Like that's a higher mortality rate than someone coming in with a STEMI.
That's fair, and I don't dispute that at all. But I think the leaf that needs to be picked off that tree is we're not talking about ignoring a patient with sepsis without septic shock. What we're talking about is the difference between treating them as an emergency in which they're going to be put into the normal ED flow. They'll get seen, they'll get recognized as sepsis, they'll get their antibiotics, they'll get whatever fluid is deemed appropriate, but they're not going to stop the entire mechanism of the department to prioritize these patients. You get a patient with pneumonia and they're tachycardic and they're looking crappy and they're febrile. That patient's not critically ill, but they are treated as an emergency. We will treat those patients with the alacrity that their condition deserves. That's an emergency. It's not a critical illness. I think surviving sepsis has moved to thinking that sepsis is a critical illness. And that would be fine if we just had septic patients appearing in our department. But every single move towards increasing the urgency of one subset of patients in the emergency department is at the expense of another subset. There is no slack. There's no margin here. All we have is an already time-limited situation for every patient in the department. Every patient you prioritize is at the expense of another patient. And I think the guidelines are falsely prioritizing septic patients who don't have signs of septic shock. Maybe I'll make this more concrete. If you have a patient who's septic, and they get their antibiotics at 1 hour or 3 hours, there's no difference in those patients' mortality from every bit of evidence. And I think we could extrapolate that to a lot of things. And yet we're making the belief structure that these patients are the same degree of criticality of a patient with a MAP of 45.
Yeah, so I think, so speaking specifically on the antibiotic recommendations, right? So for people who have like definite or probable sepsis, that means like they've been evaluated. You've determined that they have sepsis. And yes, there is a strong recommendation that those patients should get antibiotics in an hour. And when I think about what does that mean from a pragmatic standpoint, that means like from the time that you order the antibiotics, like you've decided this patient has sepsis and needs antibiotics, they should get to the patient in an hour. And we consistently see that is feasible in hospitals. And when it's not happening, it's often because there is some kind of structural issue that can be fixed, right? The orders are defaulting such that if it's a 3 times a day antibiotic, it defaults to that next time, or things like this that like are fixable issues, yes. And then for patients where you're not sure, that's where we carve in this time for further assessment, right? Improve your pre-test probability for whether this is infection versus something else. And if still after this further eval, the thought is infection, go ahead and order the antibiotics.
I'm going to put a pin in the specific antibiotic discussion just for a sec, because I think this philosophical one still might have some fruit that could be born. I don't consider sepsis a critical illness. I consider it an emergency. We treat all emergencies in a timely fashion when they present in the emergency department. But it's not a critical illness. They don't need to go to the critical care area of an ED.
Fair enough.
They don't need to be aggressively resuscitated. The flavor of the guidelines, and more so this iteration than previous ones, is making it feel like sepsis is a critical illness and not an emergency. And we can make the same statements about a patient with pneumonia. Their mortality rate, given the patient to get pneumonia, is quite high. And yet we don't consider pneumonias to be a critical illness. They can absolutely be emergencies.
Sure. I agree. I wasn't clear exactly what you meant by critical illness. I agree. It's an emergency, and not all these patients absolutely do not need to go to the intensive care unit. 100% agree.
But a little bit more than that, which is, and I think maybe this is the disconnect from a primarily ICU-based surviving sepsis campaign committee versus the emergency viewpoint. Patients don't get antibiotics in an hour. And I'm not speaking about antibiotics specifically. I'm just using it as an example here. They don't get antibiotics in an hour unless you stick them in a resus area or you call a code sepsis on a patient because they meet sepsis criteria. And then, yeah, sure, those patients might get their antibiotics within an hour. They might get their 30 mLs per kg of fluids for a lactate of 2.1, but it's at the expense of all the other actually really sick patients and potentially critically ill patients in an emergency department. That's the only way that happens. And I can understand doing that for septic shock. I can't understand doing that for sepsis patients. They're going to get admitted to the hospital. They're going to get their antibiotics. They're going to get whatever fluid is needed. And it might not be in as timely a fashion as a patient who has septic shock. And I can't see a shred of evidence that tells me that that's a problem. All of the data points to, yeah, if you wait 12 hours to get a patient their appropriate fluid resuscitation, if you wait greater than 6 hours to get antibiotics on board, we could start seeing signal of issues. But the flavor of these guidelines makes the only way to get the things done that they're asking for to treat these patients like they're critically ill, to stop the care of other patients, to prioritize them.
Yeah, I'll push back.
Please.
So I think if you think about the sort of just broad literature, I think we can say, like at a high 50,000 foot level, there have been hundreds of studies looking at antibiotic timing, right? And so you can pick any one and like you find this and that association, whatever. But at just a high level, like the longer the time to antibiotics, the increased mortality, and that association or relationship is much stronger in the patients who present with shock or who present with hypotension. I think that it's, doesn't make any kind of plausible sense that there's like a threshold, right? Oh, it's fine till hour 2 and 59 minutes, but at 3 hours, something else altogether happens. So these are gradual things that mount over time. And when we think about this, we say prioritize these patients in shock, prioritize these patients in hypotension, even if they're probable sepsis or possible sepsis, give antibiotics quickly. For patients who you've already determined, like you've had the evaluation, you've determined they have sepsis and you've ordered antibiotics, like those should be given quickly. Like I just don't see a reason not to do that. And I don't think that it has to necessarily take time away from other patients, right?
What you just said makes complete sense, but that's not the way it happens. The way it happens, at least for the performance metrics, is patients have labs sent that now is a time zero for recognition of sepsis. Yeah. And then their antibiotics, you get given at the 2 hour and 50 minute mark because that's how it plays when you're managing 15 patients at once and they're not critically ill. That's not a fallout in my mind. That's fine. That patient's fine. Yeah.
So I think a lot of this comes down to like frustration between how guidelines get translated into performance measure.
But you said yourself that you're okay with the understanding that your guidelines will be in the United States converted to performance measures. And even though there's, by your own grading, very low evidence to support some of these measures, because of the strong recommendation, they're going to be made into CMS measures. That responsibility has to be reckoned with and accepted. We can't just throw up our hands and say, we're just writing guidelines here. It's CMS's fault that they make these metrics as they do.
Yeah. So first of all, these are meant to be like international guidelines. Yep. And this is an issue that is like uniquely comes up in the US, right? Like we have 23 countries represented on the panel. Sure. We have professional societies from all over the world, right? And so there's a frustration how guidelines get translated to performance measure. I don't think the solution is to say, oh, we'll just make the guidelines to be like, here's the bare minimum you can do. Don't worry, like mortality won't get up. Just take 6 hours, do what you want. I think we want these to be like, we're trying to push care forward, right? You want to be trying to do these things. It's not a possible 100% of the time, but that doesn't mean that we shouldn't be trying, right? This is still one of the most common causes of in-hospital mortality. I run a sepsis registry in Michigan, right? Like we track time to antibiotics. We track time from antibiotic order to antibiotic delivery. We consistently see that it's possible to order antibiotics and get them delivered within an hour.
Yeah, you said this to me. Oh, go ahead. I'm so sorry.
I just think it's a frustration about the way like time zero is measured. There's, I think, an art or also some science in terms of taking guidelines and putting them into performance measurement. And I don't think that the answer is to say, oh, our guidelines should never be used for performance measurement or to drop our standards because we're afraid that it's going to lead to like unfair translation. I just think that's like a disservice to the broader field and to patients.
You said this to me the first time we spoke, and it was really one of the most powerful things you said. And I can't find any disagreement with it. You are writing for an international, you're writing for the world, and this ridiculous performance metric thing is something unique to the United States. So I completely grant that, and I hear it. Let's, though, talk about the evidence for antibiotics in patients with sepsis without septic shock, because I think at this point you might have, as a committee, gotten ahead of your skis, because I'm looking at the literature actually quoted in the guidelines that this is the literature supporting these recommendations. I'm not going to my own papers, and there's plenty of them that would be further chipping away at this argument. So when we look at it, we have 2 RCTs, FRUND and the Fantasy trial, both of which are negative for early antibiotics. We have a retrospective cohort that is not supportive until the 6-hour mark for any increased mortality for sepsis without shock. And then we have a meta-analysis of all of the extant literature that they could find at the time Lung et al. Published, which compellingly says in patients with sepsis without septic shock, there is no change until the 6-hour mark, and maybe an intimation at the 3-hour mark. And if you look at the ED, it's even worse. For the ED, there's not even an intimation at the 3-hour mark, and it really is a 6-hour thing. And I hear you, like there's not a clear time cutoff that's, oh, now the patients are going to die if we don't give antibiotics. But to choose 1 hour when the evidence listed as supporting it is directly contra to it doesn't make a lot of sense to me. It would, if you said, yeah, sepsis without septic shock, that's probable or definite, 3 hours, that would be a number that would be supported by the evidence. There is a signal there. To choose 1 hour, it doesn't make a lot of sense. Now, if you folks had said within 3 hours, but as quickly as possible, or ideally within 1 hour, that would be something supported by evidence. And this, you folks have hey folks, but you know we're not getting right to the show because you're listening to the free foam feed of EMCrit rather than the members only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that, you're hearing this and now 8 minutes from now, you're going to be listening, super excited by what you're learning, and then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed. And you never have to hear this message again. Please consider joining. And thank you for listening. Acknowledge this by the fact that is one of these strong recommendations with grading by your committee as very low certainty evidence. Should there even be strong recommendations with very low certainty evidence for things that are not just generally accepted good practice?
I guess I would say not all very low certainty evidence is created equal, right? Sometimes that means we got one study, and sometimes that means we have massive studies. And for this one, it's, I think, much more about the threshold effect, right? Like you're not going to find to say, oh, yes, like magic happens at 1 hour. But again, zoom out 50,000 feet. We know that mortality goes up with delays, right? And that the longer that delay is, the more that goes up, the sicker the patient it is, particularly if they're hypotensive or in shock, right? But that doesn't mean there's not any like measurable harm if it's some shorter amount of time. So these are like sort of judgments, I would say. And for us, when I think about antibiotics within an hour, you have decided this patient has sepsis. There is no reason to delay. And I think that the available data suggests that for the most part, this is feasible. Like you're putting an order in. This is a systems issue. This isn't about detracting all of the attention somewhere else.
Hey, this is Future Weingart just popping in here. I just want to talk about, because a statement Haley made, which I didn't want to belabor at the time, but I think it is important that we understand this, of a direct link between delays in things like antibiotics, but in other interventions as well, and then mortality is a clear causative link. And it's not. And we know this, especially in sepsis, that the reasons why patients have delays oftentimes confound mortality. A patient who might be very difficult to diagnose also has a higher mortality for the things that made them higher to diagnose. And the classic example I'll put is a cirrhotic patient who comes in and their vital signs are perturbed compared to a normal patient, but might be completely that patient's norm values. They might be septic, and their hypotension and their all of their assessment points to they're just at their standard state of cirrhosis. And yet those patients will have a markedly higher mortality. So it takes longer to diagnose them as septic, and they die at a higher rate. But that doesn't mean that the delay in antibiotics from the desired 59 minutes to 2 hours and 30 minutes had any effect on the mortality. This confounding only gets worse when later on we talk about interventions like giving 30 mLs per kg of fluids. You look at this and you say, oh, this patient didn't get 30. They only got 22. And their mortality went up in these cohort trials. It must be that we should have given them 30. But no, the exact reasons in patients that make us say, in this patient, I'm feeling a lower volume of fluid are also things that increase the patient's mortality. For instance, you get an end-stage renal disease patient and you look at the Clovers data and you say, I don't really want to give this patient as much fluid. I'm going to be more restrictive. But the fact that this patient has end-stage renal disease means their mortality is going to be much higher if this patient gets sepsis. And so their mortality will be higher, and we will have given them less fluid. But there is no causative connection between giving less fluid and the patient's mortality coming up. That is a cognitive error to assume that. All right, let's get back in. Okay, I'm hearing you, and I'm granting you that's true. If what was written was antibiotics ideally should be administered in patients with sepsis without septic shock within 1 hour of the clinician writing an order, that would encompass a very fair, I think, systems representation of good or bad. If I have a septic patient, I write an order for the ceftriaxone, I would hope it would be in within an hour. But that's not where the failures happen. The failures happen from the time of ostensible objective truth in the world, the patient has a lactate of 2.1 to clinician recognition. And that's where the problems are. And there's nothing in these guidelines that speak to that. And as a result, the interpretation clearly is going to be from the time objective truth in the world rather than recognition by clinician. You have which is an impossible thing. It's been proven to be impossible. We had this farce foisted on us when the antibiotics for pneumonia measures were enacted. And the only way to actually get antibiotics in those patients within, now I believe, was it 4 hours or 6? I don't even remember, but it was certainly better than 1. The only way was to hand them out like Tic Tacs at triage for every patient who was coughing to give antibiotics. That's essentially what we're in if they choose to take up your sepsis without septic shock 1 hour as a measure. And I know it's not your fault that these measures happen, but I think some responsibility still must be borne. The way it is written, the only way that will happen is giving every patient who presents at triage with some degree of illness that could be sepsis to give them antibiotics at triage. That's the only way it'll happen because they're not going to be put in a resus area. And as soon as that is not happening, we can't get antibiotics within an hour.
I can tell you how we do it in Michigan
I'd
in our
love to.
statewide
Yes,
collaborative.
please.
We've taken a different approach to translating the guidelines into performance measurement. So our registry and our initiative focuses on patients with community onset sepsis, which basically means that we screen patients based on diagnostic codes, but then there's an abstractor who does a chart review. These are all patients who present with evidence of infection and acute organ dysfunction. And so then the things we report out are time to antibiotics in patients who present with hypotension, and we give 3 hours from time of ED arrival. And the idea is the first 2 hours are the get to know your patient time, and then an additional 1 hour to meet this kind of 1 hour for septic shock. And then for patients who present normotensive or hypertensive, we give 5 hours. So again, the 2 hour get to know your patient, and then the 3 hour window. And then we also track out this time from ED arrival to antibiotic order, and then from order to admin to try to break down this timing. That's how we have translated guidelines into performance measurement.
It's more reasonable, what you just suggested. That would certainly be better, but that's not how CMS sees it currently. And I hope they would take the enlightenment that you just espoused. That would be good. I don't have high hopes. All right, let's move on to fluid administration. So the 30 ml per kg initial bolus was kind of elided as just blaming it on previous guidelines. And I can understand that. It did happen before this current iteration. But it's still bad. And I still don't quite understand how it took place. Now, what has happened subsequent to prior guidelines is that we have the ESICM going with up to 30 mLs per kg, which I think would have been a perfect choice here. We could have been even more prescriptive and said 20 to 30 mLs per kg, and we would have been keeping with pretty much every piece of evidence I could find is somewhere in that range. All the big 3 trials, most of the subsequent work that's come out, Clover's, it all would really sit very nicely in a 20 to 30 ml per kg world. But surviving sepsis has continued to stick with this 30 mLs, which as far as I could see was pulled out of a hat in prior guidelines. I can't figure out where they decided, except for the statement of one retrospective trial where 30 mLs per kg was suddenly tacked on to a very clear 20 ml per kg early goal-directed therapy pathway. So maybe I'll just give you the space to broadly comment on that, and then we'll go into some specifics on the initial fluid bolus choice.
Yeah, so there's no prospective trials that have looked at 30 ml versus some other specific volume. So this was, I would say, initially some sort of estimate. But at this point, it's been included in bundles that have been rolled out, New York, Kaiser, different places, and consistently shown as use of this goes up, mortality goes down. And then this is the kind of often sort of nadir in terms of what I would say is generally a very large U-shaped curve, right? Like too little fluid, mortality goes up, too much fluid, mortality goes up. And then we're all trying to find this kind of perfect spot in the middle, right? Enough, but not too much fluid. So.
Yeah, I was the co-chair of the progenitor of the entire New York project. So I know how this sausage is being made. And any study that looks at whether prospectively or retrospectively, bundle adoption as a link to mortality is going to be hopelessly confounded by all the reasons specific patients don't get the 30 mLs per kg. And oftentimes those are the patients that have a higher likelihood of dying. And it's just not going to work. So I am very leery of using any of this quality assurance type data as real. We have multiple randomized controlled trials all sitting between the 20 to 30 ml mark.
For the initial pre-randomization fluid?
For either the pre-randomization fluid or the initial bolus fluid plus the pre-randomization fluid, which would be closer to what the measure is really asking. It's all in that 20 to 30 ml range. Promise, 1950 to 2000 mLs. Process, 2083 mLs. And then even when we look at the point estimates, there's a failure of recognition that a bunch of patients got less than that in order to generate that mean fluid in these studies. So this 30 mLs per kg is a consistent point of contention that doesn't really stick with the current evidence that is making me feel like lower volumes have a signal, especially in select patient groups like end-stage renal disease, of
I can tell you mortality. We have looked for those people in our Michigan registry and we have not found. But yeah, I don't have more sort of illustrative things to say other than we've looked at this extensively in our Michigan data and tried to see are there pre-specified patients we can find that are harmed or not benefited by 30 mLs per kg, and we really can't. And I would say that the harms are consistently in a much higher volume. And then finally, I would say this is a guideline. This is not meant to be etched in stone. Every single person must get 30 mLs per kg. This is a conditional recommendation. We specifically say multiple new remarks have been added. Consideration should be given to individual patient characteristics and contexts. Clinicians should perform frequent ongoing assessment. We also have provided a table that has the actual volumes of fluid, which for the most part is 2-ish liters, right? It's not enormous volumes. And then we additionally have a conditional recommendation for using dynamic assessments of fluid responsiveness to guide ongoing resuscitation. So like when I think at a high level, like what is the difference between the ESICM guidelines that say up to 30 mLs per kg and then personalized resuscitation versus ours, which say give 30 and then go to personalized resuscitation? It's an idea of what do you think is going to be okay for most patients? I think most patients are probably going to be fine with their 2 and 2.5 liters. It's going to be harder to off the bat, personalized every single patient. But absolutely, it's a conditional recommendation. If you have a patient in front of you that you're like, gosh, I'm really worried about this patient, by all means, go to sooner personalized resuscitation.
I appreciate you saying that, and I appreciate you actually putting in those statements that give the space for individual resuscitation. I will say, though, and you might disagree, we'll see, what you guys have done by sticking with the 30 is you've eliminated the safe equipoise for a study to be actually done.
Oh, no.
And let me finish that point and we'll see if you continue to disagree. You might very well, and you might have a strong point. But I don't know, if I was on an IRB, I would say these guidelines as written make it very difficult to say the randomized control trial we actually need, which is simply a pragmatic trial with 20 mLs per kg empiric versus 30 mLs per kg empiric, is much more difficult to do with the guidelines as written.
So I would definitely push back on that, right? So this is part of the reason we put a lot more of the method stuff into the actual document this time, as opposed to just in a supplement that like truly no one will ever read. So table 2 says, what are the implications of strong versus conditional recommendations for researchers? Conditional recommendations, additional research may be warranted, may change future recommendations. So I would definitely say, by all means, anything with a conditional recommendation, there is a good argument more research could change. And there are trials, right? I mean, there's EVIS trial, right, in the UK, early vasopressors and sepsis. There's Arise Fluids, I believe. There's other trials already happening trying to get at this. It's really hard, right, to get to patients soon enough, especially depending on the sort of regulatory environment of a country and whether individual patient consent is required. But I do not think that having this conditional recommendation is the reason or is halting further research.
The problems Nate had getting Clovers off the ground.
I don't think that had to do with the guidelines, but tell me more.
I think certainly the guidelines informed people's feeling that this was like a grotesque act of butchery to give these patients a restricted volume resuscitation. You don't think the guidelines had any part in the community outrage?
I don't know. I don't know enough about the details, but I do think that there's sometimes like concern arises when people are randomized to 2 different protocols, right? And so like in the UK for the 65 trial, right, they were compared to 60-65 MAP versus usual care. So I think that there is sometimes concern when usual care, whatever that is, and ill-defined and variable is not a thing. And so I think some of the issues with Clovers was that you were being randomized to 2 different protocols, which people thought were maybe like flanks of the distribution of what's happening as opposed to a true usual care.
To continue with the fluid administration discussion, the lactate was downgraded, I think, in terms of its linkage to the necessity of additional volume administration appropriately.
Yeah. Okay. Yeah. There was no change in like strength, recommendation, or grading of evidence. I don't believe.
But I mean, downgraded simply in emphasis. Yes, exactly.
Yes,
that's what I mean.
Yeah. De-emphasized.
Yes. Yeah. But it's still there. And I think take home from people reading it is that elevated lactate still has and let me get the exact line here. Okay, here we go. So yes, this is what I was alluding to. So it's the lactate decrement now rather than lactate normalization, but it's not really the lactate decrement either. Lactate and the necessity of additional fluid are really an unlinked.
Sorry, where are you seeing lactate decrement? Oh, I see. Yeah. Fluid administration should be individualized after initial fluid bolus and monitoring of lactate decrement rather than continuing fluid until lactate normalization is achieved. Yeah.
Yeah. So we've moved from normalization to decrement, but we're still clearly linking lactate and volume necessity. And that link doesn't exist to my mind.
Yeah. So fluid administration should be individualized rather than continuing.
That part's good. Yes, we're
normalized.
Lactate decrement doesn't help me guide fluid decisions on my patients. The reason their lactate is elevated is generally systemic, adrenergic, and inflammatory tone. And this continued link between lactate decrement and fluid is still going to have people giving fluid to see the lactate come down, when probably what they should be searching for is a lack of source control or some continued nidus for inflammatory response in the patient.
Yeah, I guess I would say try to make the intention clear. It is hard, right? Like if you read the narrative, the panel emphasizes clinicians should consider lactate trends with clinical assessments such as hemodynamics and organ perfusion. Fluid administration should be individualized. Excessive fluids to normalize lactate may cause harm. This is part of the ongoing assessment of what is the trajectory of my patient and tells you that there are ongoing issues. But the message here is not intended to be like, just keep on giving fluids. So that's not the intention. But
what's your practice, Haley? Are you using lactate as an indicator of the necessity of additional volume?
I'm using it to sort of understand the trajectory of my patient, right? Like I have a patient that comes in that's critically ill and their lactate normalizes. Fantastic.
Yep.
Of course, that's not the only thing. No one can never hang your hat on one thing. But if I'm checking lactate and like, it's not going down, or gosh, it's going up, that's very worrisome. That does not mean, okay, automatically order a fluid bolus. No. So like we have rolled out non-invasive cardiac output monitoring. So we essentially do the Ivor Douglas fresh trial algorithm. Have implemented it across our ICU. We do passive leg raises, we do stroke volume change, and we use that to guide fluid resuscitation. But lactate is one of those things that tells you like this is an ongoing active patient. The problem has not been fixed. Also tells you like, why else is my patient so sick and not fixed? Do I need to reconsider the antibiotics? Is there an ongoing source control thing that we've missed? Like it's just a sort of a marker of things are not fixed.
Yes, we're in complete agreement. I think my fear is that people will read the lactate decrement as...
Now you fixed it with this podcast, so it's good.
We'll see how many people change practice. Okay, so you mentioned something that was on my next question, which is you folks are advocating appropriately fluid responsiveness measures for additional fluid after the initial bolus, but are not taking into account recent thinking on fluid tolerance. And we have patients who might...
a hot topic.
Yeah, they might be responsive, but it doesn't mean that A, they're going to be tolerant. But more importantly, in my mind, it's ignoring the fact that these gains in a fluid responsive patient are short-lived. And it's not speaking to the cycle we see consistently in every hospital I've worked. Hey folks, but you know we're not getting right to the show because you're listening to the free foam feed of EMCrit rather than the members only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that, you're hearing this and now 8 minutes from now, you're going to be listening, super excited by what you're learning, and then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed. And you never have to hear this message again. Please consider joining. And thank you for listening. Which is the ICU. And I've been on both sides. So I understand the issues on both sides of the game. But we're not going to take this patient whose MAP is 61. Just give them another liter. And okay, check volume responsiveness. Oh yeah, they're volume responsive. I guess we could get away with that another liter. And look, lo and behold, their MAP's 72 now. Yay, let's put them on a floor. But it's ignoring the fact that 45 minutes later, that patient's going to be right back to the MAP they were. So is fluid responsiveness really what we should be looking for in this fluid game, Haley?
Yeah, there's been a lot more attention recently to fluid tolerance. I will say this has been a hot topic in the past 6 months to year. It was not like when we set out to making these PICO questions. And I'm still unaware of any kind of prospective algorithms that are taking fluid tolerance into consideration and guiding resuscitation based on that. So I think it's absolutely, we need more research. Maybe these are the patients who need albumin, right? But I'm hesitant to say that we can make a guideline. There's just not evidence, right? This is like a clinical observation. So for me, I'm like, these patients who are fluid responsive but have poor fluid tolerance, those are higher risk patients. They may be reason to go to ICU. They may be reason to do albumin. That's not going to be like a guideline recommendation. But in terms of, I'm hesitant to say, we should withhold resuscitation in those patients because it's also not good to be in shock and intravascularly volume depleted. And if you're leaking that fluid out, you see what I'm saying?
I do, yeah.
This is where there's more work to be done, where we need more research to guide it. But it's not, it's at the edge of evidence. That's not a guideline thing, I would say.
All right, that's fair. My physiology buddies in the ICU will just destroy me if I don't ask this one. But there was a statement made that mean arterial pressure is a key determinant of mean systemic filling pressure, which in turn is a major driver of venous return and cardiac output. We don't find that MAP has really much to do with mean systemic filling pressure at all, just from a physiologic perspective. I have a bunch of ICU buddies who just physiology is their game. And that statement was just a real thorn in their side.
Got it. So which recommendation is this in?
It is in 13 and 14. And it's the first line underneath those.
The map, the targets. Yeah.
That's just not, it's just not true. MAP has maybe nothing to do with mean systemic filling pressure, maybe like a tiny little bit, but it's all stress volume and venous tone. That's mean systemic filling pressure. But this is picayune. But they just wanted me to mention it, that we have a glaring physiologic error in the guidelines. But
okay, we will look into that.
All right, fair. I love it. All right, so those were the big ones. I guess if we just did some tiny ones, are you doing selective digestive decontamination in your patients, Ellie?
We are not, no.
But yet the guidelines recommending them. But none of us feel that it's a good idea in the actual ICU doctors that I associate with. And I didn't do it in my practice.
I think, so why do we put this in the guideline,
Yes.
right? It is one of the things that we have actually the most randomized clinical trial evidence of on compared to many of the therapies and things that we do in the ICU. And yet it's never been in guidelines. And it's one of those things that just exists in the world. Like, we don't want to just answer the easy questions or the questions that everybody sort of already agrees with. So this was prioritized, right? This is something that has evidence. What does the evidence say? I think it's one of the most probably misunderstood treatments, right? So people think, oh gosh, we want to do antimicrobial stewardship. Like, why would we ever want to go and put antibiotics in all of our patients? Makes absolutely no sense. But there's a lot more nuance in it than that, right? This is like a very specific sort of regimen of antimicrobial therapy, IV, but also oral and topical. And it's meant to specifically target gram-negatives, right? And preserve the healthy gut anaerobes. And the evidence suggests that it works, right? Maybe we should be doing it. Maybe we should reconsider, like, why have we not done this all along? Maybe it's been a misunderstanding and that this isn't just giving more antibiotics, but about a very specific type of antibiotics. So I'm considering it.
If Andromeda Shock 2 was available a year earlier, would it have had a significant bearing on the guidelines, or do you look at their outcome measures as not really strong enough to have a change?
That's interesting. It's a quite complex algorithm. And so that the harder something is to implement, I would say that the more evidence it is needed, whether that's cost or staff time and all that kind of stuff. So I don't know, but I think there's concerns about the feasibility of that algorithm across ICUs.
In some ways, it is complex, and yet it requires simple measures, right? That's an advantage of it. In fact, it was created to be in low-income settings that might not have even easy availability of ultrasound, much less any of the advanced mono. In that sense, from an international perspective, it might actually be, while somewhat complex to read the algorithm, very much more implementable than some of the other measures.
Yeah, I mean, in terms of like devices and stuff, but in terms of staff time, it does feel like it would be more intensive. I think the editorial was like fantastic for that paper. It discusses the challenges of how do you take this trial and move that in. And that's a sort of a recurring theme of sepsis is how do you deal with these kind of bundled interventions, especially if you like part of the bundle and not other parts of the bundle. And I think that comes up again here, right? There's sort of pieces of the algorithm that it was unclear how they got there. And then other things like capillary refill that, may be a true like helpful marker of perfusion and obviously like changes in real time. So that may be helpful. But again, there's the kind of this always question of, gosh, is all of those pieces really all necessary? Or maybe this is more about, well, we should be incorporating capillary refill more readily and like consistently into practice.
Yeah, fair. All right, Hallie, what haven't I hit that you want to get across to mostly EM and critical care docs reading these guidelines?
Yeah, I think that we've talked a lot about the early resuscitation and the timing of antibiotics. I think that there is, a general movement away from just like broad spectrum. Absolutely make sure you don't miss something to be like, gosh, we focus so intensively on time to treatment for a long time, but we should also be thinking about what we're treating with. And this kind of recognition that probably we have been over treating some people for some time. And so there's these new conditional recommendations about anti-anaerobic coverage, which sometimes is specifically antibiotics ordered for anti-anaerobic coverage, like Flagyl for aspiration pneumonia that like almost certainly can go away. And then I think other times it's that we have a lot of times where the guidelines will tell you could do, either of these antibiotics, but one of them covers anaerobes and the other doesn't. And generally, if you don't need to cover the anaerobes, you shouldn't. So a thought about being more narrow. There's also changes about empiric antifungal therapy, but that's probably more in the ICU space than the emergency department.
Yeah, it's interesting. A bunch of the ID listeners wished in some ways that there were empiric antibiotic guidelines for various septic conditions in these guidelines. And I could see both sides of that issue. I could see staying away from them. It doesn't age as well when they have those recommendations and guidelines because the evidence changes so quickly. But did you folks consider,
that's been something that's been talked about. It's just such a challenge, right? Like you think about just the number of sites of infection for sepsis. You think about the antibiograms around the world and like differences in pathogens from country to country. I think it's just not really feasible, right? We point people to guidelines for pneumonia or guidelines for different specific types of infection. So it's really been more of like a strategy. And I would say it's a slow movement towards just broad spectrum antibiotics, cover everything possible to be like, think about what we really need here.
Yeah, that's fair. So I guess the last question I'd ask is, ACEP did not endorse. So what has been Surviving Sepsis Campaign's, and you might say you only want to speak for yourself and not them, but what's been their response to that? And is that going to affect anything going forward?
Yeah, so I guess I'll just speak on my own behalf because I don't necessarily have
You're not wearing the robes
to speak on like everybody. But yeah, obviously you want everybody to be on the same page. I think there's some sadness when everybody's not on the same page. But at the same time, we had good involvement from the representative from ACEP. ACEP was a sponsoring organization, just not an endorsing organization. I think with each additional iteration of the guidelines, the panel has been like more diverse in terms of proportion in low and middle income countries, the distribution of the types of clinicians on the panel, and I anticipate that trend will continue. We did have a number of emergency medicine physicians on this panel, a number of other emergency medicine professional societies. It's like, it's like, you try to do a good job and then you next time pick up and try to do a better job. Yeah.
Well, I can't thank you enough for coming on, Haley. This has been wonderful. And thank you for all the hard work you did to make this actually go out into the world.
Thanks for having me.
All right, folks, that was the interview portion. I just want to finish up with some of the non-contentious areas of the guideline. Well, some of them might be a little contentious, but I didn't want to actually do them during the interview. So I'll just go through a few of these, and that will be a good way to finish up. All right. Code sepsis. For hospitals and health systems, we suggest using a code sepsis or sepsis huddle protocol over not using such a protocol. And this is a conditional recommendation, low certainty evidence. I'm sure there are hospitals that benefit from this, hospitals that are not used to moving quickly on septic patients. It's not any hospital I've ever worked at. I find these code sepsis or sepsis huddles to be an absolute waste of time. I find them to be annoying as hell, and I don't find them to be utile. When we have a patient with septic shock, we're doing the sepsis huddle without having to call it that. I'm talking to the nurse and saying, here's the vasopressors we need, here's how much fluid I want. We're doing that automatically. And for sepsis patients, as I've continued to allude to in the show, you don't need a huddle, you don't need a code sepsis, you don't need any of that stuff. Maybe our hospitals are outliers. I don't think so. I think this is silly. All right, blood cultures. They're recommending, and this has been the consistent recommendation, and it's fine, for adults with possible, probable, or definite sepsis, we recommend collecting blood cultures as soon as possible and ideally before administration of antibiotic therapy. This is worded perfectly. It's just as it should be. They mess it up, not the Surviving Sepsis Campaign. The CMS messes it up when they make it into metrics. They eliminate all of the language that makes this right. I just wanted to mention it because in the discussion, they mentioned the systematic review on single site sampling, which showed it's no worse than taking 2 blood cultures from separate sites. So this is what I think we should be doing on most patients. If you suspect endocarditis, it's different, but I think we should just be getting 2 sets of blood cultures from the same site in most patients. I think this additional stick is not necessary. All right, vasopressor timing. This one was contentious for a lot of people. I think at a guideline level, they did it right. I would actually vary my practice, but as a guideline, I think it's fine. For adults with sepsis-induced hypotension, we suggest IV crystalloid bolus followed by vasopressor support if hypotension persists. And that's conditional, very low certainty evidence. But then they say in patients with unstable septic shock, immediate concurrent administration of vasopressors together with IV crystalloid may be warranted on a case-by-case basis. I think this is right for a guideline. It's not how I practice. I am moving towards vasopressors much sooner on many of my patients, but I think that requires a level of discernment. So I think they did the right thing for a guideline. Some of my folks on the ACEP committee, they disagreed. All right, vasopressor route. I love this. In adult patients with septic shock, we suggest starting vasopressors peripherally to restore mean arterial pressure. That should definitely be in a guideline, and it is. It's fantastic. All right, the MAP goal. For adults with septic shock, we recommend an initial MAP of 65 over higher MAP targets. I think that's good. And for adults who are 65 or older, we suggest an initial MAP range of 60 to 65. And that was based on a recent publication. I think that's all fine. Now, this is the spot where the MAP being the key determiner of mean systemic filling pressure came in. I've already discussed that. All right, admission location. For adults with sepsis or septic shock who require ICU admission, we suggest admitting the patients to the ICU within 6 hours. What needed to be added to that statement that is lacking is unless the ED has an ED-ICU or similar setup, in which case that they don't need admission to the formal hospital ICU within 6 hours. I think we could show very easily, if we haven't already with the extant literature, that we are just as good as the ICU upstairs. All right, fluid choice. For adults with sepsis or septic shock undergoing initial resuscitation, we suggest using balanced crystalloids over normal saline. And yeah, I think it's a good rec. I don't think it's very evidentially supported. They say moderate certainty evidence. I'm not sure about that. I do it. I think it's the right thing to do, but I don't think the evidence is as high as moderate certainty at this point in the game. All right. Fluid conservative versus liberal. For adults with sepsis or septic shock who have received initial fluid resuscitation with 30 mLs per kg and have persistent hypoperfusion, we suggest either using liberal or restrictive fluid resuscitation strategy based on individual patient and health system factors. Well, that you can't beat that. That's just fine. All right, serial lactate. For adults with sepsis and elevated lactate or septic shock, we suggest using serial lactate measurements to guide resuscitation. Yeah, I guess they could get away with that because they didn't say guide fluid resuscitation here. We've already mentioned where they did say it, and that is not good because that's the next line. Fluid administration should be individualized after initial fluid bolus and monitoring of lactate decrement rather than continuing fluids until lactate normalization. I've already mentioned that's bad. Get rid of that. All right. CRT, which is capillary refill time in this regard. For adults with sepsis or septic shock, we suggest using capillary refill time to guide resuscitation as an adjunct to other measures of perfusion. That's fine. I don't have a problem with that. All right, vasopressor choices. I already mentioned that Corbin didn't like these, and I'm fine. I'm fine with this entire section of their vasopressors as long as it's a guideline, as long as it's understood. This is for a lowest common denominator. All right, for adults with refractory septic shock and escalating vasopressor requirements, there is insufficient evidence to make recommendations on methylene blue. I think this is correct, and this is my read on the literature as well. Is I don't think it's ready for prime time. I'm happy to change that. Same thing with midodrine. They are saying is not ready for prime time, and I agree with that. And in fact, the evidence that we have out there is negative for the benefits. All right, they're suggesting against beta blockers as a treatment for septic shock, which is probably right given the current state of the evidence. Let's see, is there anything else that's interesting that you can't just read in the post for this episode rather than me stating out loud? They talk about vitamin D. They talk about sodium bicarb. And they do say don't use it in general, but if the patient has septic shock, severe metabolic acidemia, which is always a laugh for me, that 7.2 is what the medical intensivists consider severe, but be that as it may, and acute kidney injury, that they do suggest doing it based on bicar ICU2, which I think is the right recommendation. All right, I think that's it. I think we could stop there. Check out the post. There might be some more stuff that I didn't actually mention that goes into that post for this episode. And I hope you enjoyed. I know this was a long one, but I think it was worthwhile, at least for me. I truly enjoyed the entire conversation. I hope you did as well. But let me know. Let me know what I missed. Let me know what you disagree with in the comments for this episode. Scott Weingart for the EMCrit podcast saying bye-bye. As always, promote dignity, relief, and warmth. Very rapidly, some current projects you may be interested in. The Awake and Aware Conference, Scottsdale, Arizona, February 2027. Its Kickstarter has sold out, so the conference is live. Unfortunately, you missed the super discounted tickets, but the full price tickets are now available, and I will tell you the link at the end of this discussion. But that conference was amazing last year. It will be amazing this year. The Out on Time course, it is our charting course, our malpractice avoidance course, our getting out on time course, feeling on top of your shift efficiency. The spin class, that is our vertigo and dizziness mastery class. It is to get you to the point where you will be eager rather than dreading picking up a dizziness chart. We have the Resus Leadership Academy. That is our online fellowship to take you from emergency medicine or hospitalist to aggressively potent resuscitation doctor. You will be the person in your department leading the game on resuscitation and acute critical care. The Unburnable course, that is our burnout prevention course, our Finding Joy and Flourishing in Your Career course. That is a cohort online course, so it is done in real time, and it has been lovely. This is our 5th cohort. And then, last but not least, the Reanimate course. That is our eCPR, ECMO CPR, and resuscitative ECMO course. It sells out every year. If you want to come, the time to buy tickets is now, because every year I get people, 4 months before the conference, they're like, I really want to come. Well, guess what? You can't, because I told you for the 5 months before now that they sell out every single year. You should have listened. So if you want to check out any of that stuff, come to EMCrit.org/stuff. EMCrit.org/stuff. That's EMCrit.org/STUFF. So I've loved talking to you. I'll talk to you again soon. Scott Weingart saying bye-bye.